Thank you for joining us for this very important announcement. Today is indeed a very special day, and we're so glad that you could join us live to witness the birth of Blink Vision and get the first glimpse of how Dr. Richard Barry is shaping the future of laser vision right here in Canberra. Now, this presentation will run for approximately 30 minutes and will be followed by a Q&A. So if you have any questions, please drop the questions into the chat and we'll go through them at the very end. Now, tonight's event is intentionally small, and we wanted to personally share this with a selected group of valued colleagues and referrers only. So you are among the first to get a behind-the-scenes look at Blink Vision before we officially open our doors to the public. Now, in case we've not met before, my name is Shane Brookman, and like many of you, I've made it my life's work to help people see better. Now, after a very long sabbatical abroad in Spain and Portugal, Mexico, Brazil, and Indonesia, I've finally returned home to my true love, which of course is the profession of optometry. This year, I joined Dr. Barry's team as the new Director of Eye Care for Blink Vision, helping oversee the new Laser Eye Surgery Centre for Excellence at 3 Sydney Avenue in Barton, which is opening very soon. Now, welcome, Rose. So enough about me. I'd like to introduce our speaker tonight. And before I do, I'd like to begin by acknowledging the traditional owners of the lands on which we meet today and to pay my respects to elders past and present, as well as to any Aboriginal and Torres Strait Islander people attending this event. Thank you. Now, Dr. Richard Barry is a highly respected ophthalmologist, a retinal specialist, and a refractive surgeon in Canberra. With over 15 years of experience in surgical eye care, he has helped thousands of patients improve their vision through cutting-edge treatments for cataracts and advanced retinal disease. Dr. Barry trained at the prestigious Sydney Eye Hospital and went on to complete international fellowship training in macular and retinal disease, as well as vitreoretinal surgery. He's a fellow of RANZCO and is an active member of several specialist societies across Australia, the US, and the UK. Now, beyond the operating theatre, Dr. Barry is a dedicated teacher and mentor to the next generation of eye health professionals. He lectures at the University of Sydney and serves as an adjunct professor at the University of Canberra. His practice also plays host to many number of optometry students each year as part of their mandatory clinical training. And for those of you who know Dr. Barry as the founder and lead surgeon of Blink Eye Clinic, you will also know how passionate he is about bringing world-class technology to the nation's capital. What you may not know about Dr. Barry is that he's also a refractive surgeon that's been trained by some of the best in the business. And over the past year, he has undertaken an incredible amount of research, extensive study, and significant training overseas whilst collaborating with global leaders in the field. All of this to make it easier than ever before for Canberrans, your patients, our patients, to access leading-edge laser eye surgery without needing to travel interstate. So you can imagine the depth of commitment and the expertise that has gone into making this vision a reality for our community. And to top it all off, on a personal note, he's one of the most friendly, down-to-earth, and deeply committed doctors I've had the pleasure of working alongside. So here tonight, to unveil the future of laser vision in Canberra, please welcome Dr. Richard Barry.
Thank you very much, Shane. Very humbling words, and I appreciate every sentiment. So thank you to everybody who's joined this inaugural webinar for the Blink Vision Clinic. I'm deeply grateful for you allocating time in your own, with your personal time in the evening to support me and my team to get this Blink Vision Clinic off the ground. As Shane said, this has been a labor of love. Refractive surgery was something that I always was very interested in. I came back as a retina surgeon, but obviously developed a cataract practice. And the more cataract surgery I did, the more intrigued I was about refractive cataract surgery and refractive surgery in general. But I felt underarmed. I didn't have all the right tools and technology. Having refractive laser options really does give me all the tools I need to provide a complete refractive service, whether it's lens-based surgery or laser-based surgery. And that was what Blink Vision Clinic was all about, to house all of the refractive work in one world-class facility. So I just want to quickly thank, I hope everyone can see my screen. So look, with immense gratitude, I need to just as this is the first webinar of many that to come. I just want to thank all the people who've been involved. This has been a huge amount of work to get this project off the ground. We've worked with teams all over the world, Lively Solar in London, Professor Sri Ganesh in India, the Schwinn Laser team and Arthur, Dr. Patrick Vasatri, who's been my mentor, our architects, Anthony and Steve, who have extensive experience in laser clinics and ophthalmology practices, our interior designers, Lisa and Rose, our project management team, Rose, Jamie, Julius, Vanessa, and Shane, without doubt, has been the visionary and the director and the leader of everything. I'm so busy working at Blink Eye Clinic, and Shane has just taken everything on board with a smile. He's incorporated all these people and brought them all together to work as a team. He's a true leader and visionary, and I'm immensely grateful for what he's done. So about this time last year, I decided to set up Blink Vision Clinic, and the first thing I did was start to research, well, how am I going to upskill? You know, we train as cataract surgeons and we train as retina surgeons, but because laser refractive surgery is an elective private procedure in most Western countries, you're not going to be able to do laser eye surgery on patients. A lot of it's done by a laser, and the planning is done by, great diagnostic equipment. So I did a lot of research, and I decided to go and spend time with Professor Sri Ganesh, who's one of the leaders of refractive surgery. He's one of the pioneers. He's been around and has been the first of many refractive procedures. He's an amazing man. He's a true mentor and leader in the field. He has multiple hospitals in Bangalore. And so I spent time with him and his team for a week, and then learned so much that I booked another trip back a couple of months later to go and do more surgery. So I've done many procedures with Sri Ganesh at my side and his team at my side, teaching me how to do laser refractive surgery. Um, so look, tonight is not about launching a surgical service. It's about launching a vision of how we can better serve our patients. So Canberra has grown from a small regional town into a progressive, multicultural and internationally recognized city. And it's time that the healthcare offerings reflect that evolution. And for too long, I hear of patients seeking world-class laser eye surgery or medical care, and they feel like they need to leave Canberra, but that's no longer necessary. However, delivering excellent surgery is only part of the journey. And the word journey is important to remember. The real journey is actually lifelong for these patients with refractive error. And that journey has always and must always be guided by you, the primary eye care providers, optometrists. We as refractive surgeons are not competitors, we are partners, and we care for patients at different moments in their lives. I thought about how I would deliver this first talk, and there's obviously a lot of technological stuff that we can speak about, but really it's about fostering a partnership. And this charter is what I felt was the most important thing to deliver, that we have a shared mission, and that mission is to guide every patient through a lifelong visual journey with seamless and collaborative world-class care. We have shared principles recognizing the essential roles of both optometrists and ophthalmologists, prioritizing the patient's long-term visual needs and well-being, and maintaining clear and honest, proactive dialogue, enhancing and protecting each other's relationship with the patient, and upholding the highest clinical, ethical, and professional standards. And our commitment at Blink Eye Clinic and Blink Vision Clinic to you is to respect and strengthen your role as the patient in the patient's visual care, and to provide transparent updates before, during, and after surgical interventions or consultations, and to make available advanced diagnostics and surgical care locally to minimize patient disruption, and recognize that surgery is only one stage of their care, not the replacement of optometric relationships. Together we are stronger and we serve our patients better. So I felt like that was what I wanted really to deliver, that kind of message, that I want to collaborate. I want to know that there are patients who are going to need refractive surgery, or they're going to desire or want information on refractive surgery. And many of them will just go interstate or go and seek that information. But if we can provide them with a collaboration where we work together, then I think that's best for our patients. So Blink Vision is in evolution. It's more than bricks and mortar. A few weeks ago it was bricks and mortar, and now we have walls and electrics and air conditioning. It's starting to evolve, and these are some of the images of what it's going to look like. And I can't wait to show you all around in person. I just wanted to touch base on refractive surgery and the history of refractive surgery. As it really is, it's young, it's new, and particularly modern refractive surgery is new. Um, if we go back to 1949, when Barraquer developed the concept of reshaping the cornea to change the focus of the eye, called it keratomileusis. And in 1974 in Russia, Fodorov invented radial keratotomy. After that, in the early 80s, Trockel applied excimer laser to corneal tissue, working with the IBM team who created excimer laser for microelectronics. And the first human PRK was 87, LASIK 91, and then a big evolutionary change in 2001 when femtosecond laser came in. Previously, there was a microkeratome creating a flap, and then femtosecond laser came in to create a much more controlled flap and reduce flap complications. Diagnostic equipment improved, and only in 2011 was lenticule surgery, or SMILE, which is a Zeiss procedure, was introduced only in 2011. And the latest version of lenticule surgery is with the Schwind-Atos system called SmartSight, and that's only been since 2020. So a lot of this is new, and when people think about laser eye surgery, sometimes the two limiting factors are cost, which is reasonable, as it's not covered by health funds or Medicare, and then fear is the other. And I think fear will become less and less as technology improves, both diagnostic equipment and the therapeutic lasers themselves. So we've invested hugely in selecting the right equipment for Blink Vision Clinic. And I've spoken to people all around the world, spent hours on international late night, early morning phone calls, visiting practices, studying papers, and really trying to decide what system to use. And I felt that the best, by far, excimer laser is the Schwind-Amaris, and the newest femtosecond laser is the Schwind-Atos. And I think this combination for me was a no-brainer. It's the best laser system out there, in my opinion. So the Schwind-Amaris laser is an ultra-high fast frequency ablation. We have the 1050, which is the top of the range. It has 7-dimension eye tracking, which is it's the only laser that does that. So tracking the eye for movement during the laser procedure. On the excimer laser, which does ablation of the cornea for PRK and LASIK, patients there's no cone docking on the eye. These patients are just looking straight and the laser is ablating the cornea. And so eye tracking is critical to prevent decentration of the treatment zone. And the Amaris is best in class for doing that. The Atos has Centrax, which is a docking system that ensures that when the cone, because with femto laser you dock on the eye, and the cone docks on the eye, and it has to be centered. And many times with other devices, and I've learned this from training overseas, that centration can be a problem, getting the patient to actually keep their eye steady and dock properly. Some lasers are very quick in terms of doing the laser, but the docking can be difficult, whereas with the Atos and the Centrax, it's made much easier and much more accurate. This is a little video on Centrax. I'll probably skip past this, and I'll skip past this 7-dimension eye tracking that the Amaris has. But look, we've invested also in diagnostic equipment. So no laser is any good until the plan that the laser has been given is accurate. And that comes from investing in good diagnostics. Patient selection, optimizing the ocular surface, and then imaging and planning is the best way to give that laser its best chance of doing the work that it needs to do. So we've invested in the CSO equipment called the MS39, which is an anterior segment OCT, and the Osiris T, which is a wavefront aberrometer, as well as the IOL Master 700 and the HD analyzer and other diagnostic equipment that we have. And all of this is designed for a refractive patient, whether it's a laser-based refractive patient or a lens-based cataract or refractive lens exchange patient or ICL patient. All of these devices work together to provide more and more accuracy, to provide the best planning, lens selection, treatment planning for laser eye surgery to give the best post-operative results. The good thing about the diagnostic equipment from CSO is that CSO and Schwind are partners, and those two diagnostic devices integrate into the SWIND, Amaris, and Atos software system, and the planning is so straightforward without any risk of human transcription error. It really does make it much safer. We've also invested in the best technology for ICL planning. And so ICL surgery is a very easy procedure. An incision, and you put a lens in the front of the eye with some jelly to protect the cornea and to protect the lens. But the actual planning of surgery and the measurement is key. And so they've done a lot of study, and sulcus to sulcus measurements with a UBM is the best way of measuring for ICL surgery. Because if the lens sits too high, you can get a narrow angle, and you can potentially, if they rub their eye, they can damage the endothelium. And if it sits too low, it can sit on the lens and cause early cataract formation. So the vault height of the lens is really critical for a safe postoperative course for the patient. And so vault height is dependent on lens sizing, and lens sizing is most accurately measured when you do sulcus to sulcus measurement with a UBM. So we've invested in a UBM as well. And all of this diagnostic investment and investment in laser is really to try and reduce risk to the patient and optimize treatment outcomes, to reduce ectasia risk, higher order aberrations with wavefront aberrometry, decentration with topographical mapping, whole cornea topographical mapping, and Centrax and cyclotorsion control. Again, biomechanical weakening, so ectasia risk again. Again, full corneal mapping with these diagnostic devices can limit tissue removal or unnecessary tissue removal, which can weaken the cornea. And then treatment zone mismatch. All of these diagnostic tools are designed to reduce the risk of any of these things happening. So what procedures are we going to provide at Blink Vision? So there are surface procedures, which we know as PRK. It's called Smart Surface with the Schwind system, and it's called, and they do what's called Trans PRK. Trans PRK basically is PRK without having to apply alcohol to the surface of the epithelium to debride the epithelium. That can lead to poor postoperative refractive outcomes, regression, and trans PRK is definitely more of an optimal procedure rather than PRK for postoperative refractive outcomes. So Smart Surface with the Amaris laser, it's a single laser procedure. LASIK is a flap-based procedure, and PresbyMax is LASIK for presbyopes, where you can induce spherical aberration or monovision. And SmartSight is lenticule-based surgery, or SMILE is the Zeiss procedure, and for the Schwind procedure, for Schwind laser, it's called SmartSight. And then we have ICL surgery and refractive lens exchange. If we want to just look at a very quick video on what PRK looks like, again, as I said, it's a single laser procedure with the excimer laser. It's done on the surface of the cornea. It's one step and no touch, and very quick. It can treat a wide range of refractive error, up to -9 diopter short-sighted, myopia, hyperopia up to +6, and astigmatism up to +5. And so the laser ablates the epithelium, whereas in PRK, alcohol debrides the epithelium, whereas in trans PRK, it goes straight through the epithelium. So you can a much better accurate ablation zone, because it's planning the laser of the epithelium and the stroma, rather than alcohol debridement of the epithelium, which can lead to problems with the corneal stroma. And then once the ablation profile has been formed, a contact lens is placed, and the epithelium will heal in a few days. And with higher refractive errors, mitomycin inclusion has significantly reduced haze, which was a problem with PRK. And so that's much less of a problem with the mitomycin protocols nowadays. So lenticule-based surgery, again, it's a single laser procedure, this time with the femtosecond laser. It's one step. The laser ablates the surface of it cuts the surface of the cornea. It cuts a lenticule out of the stroma, essentially. And how it does that, if we look at the cross-section, it's a bit easier to see. So on cross-section, you can see there's a lenticule of stromal tissue. There's a cap cut and a lenticule cut and an opening or an incision. And through the incision, A spatula dissects the tissue, and with a forceps, you can remove the lenticule. You don't even need a contact lens, and it's a tiny little 2 millimeter incision, very little dry eye risk with this procedure. With LASIK surgery, then both, so femto LASIK, so it's a femto flap cut followed by excimer ablation to the stroma. So you can see the flap is lifted and then the laser starts, and in real time it kind of looks like this, like rain droplets almost. It's very quick, and as I said, this Amaris compensates for all the patient's eye movements in every dimension. It compensates so that the ablation is as per the plan, and we don't get decentration anywhere near as much. And then at the end of the procedure, the flap is repositioned, and sometimes, but mostly, there is no need for a contact lens. So ICL surgery, as I said, it's like just inserting a lens at the end of cataract surgery. We dilate the eye, we make a corneal incision, and then we use this very, very soft Collamer lens and fold it. We fill up the front of the eye, the anterior chamber, with viscoelastic jelly to protect the endothelium and lens. We insert the Collamer lens, and we tuck the little haptic plates under the iris margin and put in a constricting eye drop after washing out all the viscoelastic. It's very quick and straightforward, but the planning of the size of the lens is critical. So in terms of patient selection, I think what we'll do is probably send out information to all of you, indicating the treatments that we are going to be providing and, what type of patients will be most suitable, so that if you happen to have patients who are inquiring, then at least you have the information about what we're going to provide and our criteria. But I guess essentially, if the widest range of refractive errors, maybe LASIK has the widest range. Smart Sight is mostly for myopes, although there will be programs for hyperopic treatments in the future. Very good for patients who have dry eye because there's minimal dry eye. And Smart Surface, PRK is really a great procedure for hyperopic to myopic patients. Has less dry eye than LASIK, maybe slightly more than a lenticule surgery. It's better biomechanical stability, so thinner corneas. And I guess for sporty people who may worry about trauma from a flap, then surface surgery or lenticule surgery might be a better option. ICL surgery is probably for those higher myopes or definitely thin corneas, and it is reversible. And actually, ICL, we tell every patient, when you get older, if you develop a cataract, we'll probably take this lens out and replace it with another lens. And then refractive lens exchanges for your presbyopes and early cataracts. Regression risk is a lot less than it used to be in the past with modern laser treatments because of the amount of inflammation that's induced is much less. That stimulation of the keratocytes from higher energy laser is becoming less and less and less, and regression is seen less often. Infection risk, it's extremely low with these procedures, and these are once-off procedures, so 1 in 5 to 10,000 risk. ICL may be a little bit higher risk, but the cumulative risk with contact lens wear over many years is far greater. Maybe 1 in 10,000 per year, and if they're wearing contact lenses for 10, 20 years, then the risk really is significantly more than these procedures lifelong. So I just wanted to, go back towards what I started with, which is about this patient's journey and the collaboration between optometrists and ophthalmologists. So in childhood, we have primary eye care, vision screening glasses, which is in the domain of the optometrist. Specialist pediatric care may be required for certain patients, and we have Dr. Spargo, who has been and will be committed to pediatric patients in Canberra, and will probably join Blink Vision down the track to be one of the refractive surgeons at Blink Vision. In the teenage years, contact lens fitting, myopia management, optometrists. In young adulthood, some patients might approach you about laser eye surgery, and they may see us and have laser eye surgery, so the ophthalmologist gets involved. In midlife, people become presbyopic. They're back in glasses. They may come back to us for touch-up laser surgery. They may elect to have refractive lens exchange. In older age, patients may get cataracts. They may have monofocals or EDOFs or multifocals, but whatever lens they select, many patients will still need glasses or refractive correction. And we're both involved in the long-term monitoring and management of chronic eye conditions, a lot of which are associated with older age, glaucoma, macular disease, and general eye health. So really what I'm trying to the point I would like to kind of remember from this talk is that we're partners and we work together to, to look after our patients, to monitor and enhance their vision throughout their life on their refractive journey from childhood to older age. And our role as refractive surgeons is really probably only for a small proportion of that journey. Um, so again, tonight was not simply about launching a surgical service. It was about launching a vision for how we can better serve our patients together. We are not competitors, we are partners caring for patients at different moments in their lives. And I really just want to thank everybody for giving me 20 minutes of your time. It really means a lot to me. And thank you for all your support at Blink Eye Clinic and for Blink Clinic, Vision Clinic into the future.
Well, thank you, Dr. Barry, for sharing your vision for the future of laser vision in Canberra. Now, before we open up for questions, there's just a few very brief announcements that I'd like to make just concerning the upgrades we've been making to Blink Eye Clinic as we've been on this incredible journey of bringing the vision of Blink Vision to life. So I'll just quickly share my screen here. Now, some of you may have already received the Blink News, and this is to benefit those of you who have not. We have a new specialist recently joined the team, and that's Dr. Joanne Tiong. She, like Dr. Barry, is also a retinal subspecialist, and so Dr. Tiong is now offering laser and intravitreal injections for macular degeneration, diabetic retinopathy, and retinal vein occlusions. So she's happy to see all retina patients, but she's also seeing general patients as well. We'll also have a new subspecialist, and that is a glaucoma subspecialist called Dr. Neera Jain, joining the team from the UK in August. And on to Dr. Spargo. Many of you will already be familiar with the work that he does with kids. He also sees adult patients, and I believe that he'll be running particular clinics and flying in some orthoptists from Sydney as well. So this is just to demonstrate the level of commitment that the team of Blink has to servicing your patients, whether they be young or old. Now, it's also worth mentioning that the technology, I'll just bring back up that slide on the technology. The way we manage cataracts will also significantly change because of the technology we now have access to in Blink Vision. And that means the addition of the MS39, the Osiris T, the HD analyzer, all of this on top of the IOL Master is going to offer patients even better pre-operative evaluations and predictability of post-operative results. So all of the focus on refractive outcomes has actually resulted in an incredible benefit to both our laser and lens patients. And last but not least, if we just go back to that patient journey, wherever your patient is in their journey, in life, in vision, Blink is here, and we have all the tools to support you in delivering the best outcomes for your patients. So whether it be from glaucoma to macular disease, from retinal detachment to cataract, from pediatric to refractive, we've got you covered. So thank you so much for your time again. And I'm just going to hand back to Dr. Barry just for a closing statement before we open up for questions.
Yeah, so I just want to, reiterate what Shane has said, that this journey of going into the field of refractive surgery really has setting up a new business in this current era has been kind of eye-opening. The technology advancements, even since when I set up Blink Eye Clinic, and I thought, I'm making use of all the available technology then, and to see how things have come now, and to see what we're implementing into our practice with AI and more patient information, better communication. There are so many upgrades happening because of Blink Vision, because it opened our eyes as to what's possible. The collaboration we have with the new team of young and energetic and smart and creative people working on the Blink Vision and Blink Eye Clinic team is only going to lead to great things. So I'm really excited about the future, and Shane is leading all of this, and I'm forever grateful for him. Thank you so much, Shane.
My pleasure. So without further ado, does anyone have any questions, anything pressing? If you do, please drop it in the chat. Okay,
We
so
knew that was going to be the first question.
yes, absolutely. So the question is, how much for refractive surgery, and does it differ from PRK, LASIK, SMILE, ICL? So, Maureen, thank you for that question, and we did anticipate this would be the very first question on people's minds, of course. The truth is that it does vary from patient to patient. So you're right, it does vary depending on the type of procedure that would be most suitable for the patients. Look, to be totally transparent, there's a ballpark figure that I can offer, and that will be anywhere from $7,000 to $12,000, depending on the type of procedure. For the actual specifics, what we'll be doing in due course, over the coming weeks, you'll receive a welcome pack from Blink Vision that will outline all of the procedures and will have in it a chart with patient suitability. In the meanwhile, however, if you'd like to refer the patients to the website, which is simply blinkvision.clinic, it has a suitability self-test. And so what we're doing is basically channeling patients to go to the website and just enter their details, do the suitability self-test, and then we'll contact them to invite them for a free assessment when the doors are open in a couple of weeks' time.
Hmm.
So thank you very much for that question.
And
Next question, yes.
just to add to that, the cost. So laser surgery will happen at Blink Vision, so there's no hospital admission. But ICL surgery is a little bit more expensive because unfortunately it does include hospital fees and anesthetic fees, etc. on top of that. That's why that's on. Most of the laser fees are closer to seven, and the ICL surgery is the one that's the outlier. So that's why the $12,000 is in there because it has more fees than just the surgeon fees.
Yes, and worth noting as well that it's a comprehensive fee that includes any enhancements,
Yeah,
touch-ups, and all of the post-ops,
yeah.
definitely for the first 12 years and even beyond that. So Rachel's asking, when will you start seeing patients for refractive surgery?
Well, I think that the opening, we're hoping to start seeing patients from the 1st of July, where we should get the keys to the new clinic at the end of May, and we're going to spend the whole month of June just fine-tuning everything, getting all the equipment and diagnostics and computers, just everything kind of settled in, getting all the staff familiar, getting our procedures and policies right, and I think then we should start to see patients from the 1st of July. Is that correct, Shane? That's the
That is
plan?
correct. We're on target for the 1st of July. So we hope to, well, we not even hope to, we will be inviting you through for a personal tour. And we anticipate that that could be as soon as June. So again, stay tuned, check your emails. I'll be sending out some welcome packs as well with personal invitations for you to come through so we can show you firsthand what we've been up to in the new Blink Vision. And on that topic as well about refractive surgery, I'd just like to make a note that Dr. Barry is already performing refractive surgery. Obviously, in cataract patients, he's performing cataract surgery, but he's also been doing ICL, unbeknownst to many of the eye care community here in Canberra. He has been performing ICL, as done in
And
hospital,
Janine
obviously.
has asked, what are the likely follow-ups for these patients? So, look, many of these patients will require, most patients are going to be comfortable day one, seeing well very quickly, minimal complication risks. And so, we would like to be able to see everyone day one after any laser procedure. So we would like them to hang around for the first post-op day. I think it is to be decided exactly what those follow-up protocols are going to look like, particularly for those patients who are from far away. Obviously, with cataract surgery, it has become the norm for patients maybe to see me on the first day or just to follow up with their optometrist if they live many hours away. But with the laser patients, and particularly as this clinic is evolving, I think we'd like to be able to follow them up a little bit more closely ourselves. And, with time and more webinars and more kind of consulting with you guys who are going to be helping us, we can kind of provide advice on what to look out for, what are the features that you might see and report back, maybe how to image the cornea to send to us. So I think that's an evolution in progress. And I think for now, we'd probably like to be able to look after these patients closely within that first week.
And looking long term as well, we hope to develop education protocols. So if any of you are interested in potentially co-managing some of these patients down the track, we'd definitely love to speak with you. And a question about corneal thinness. So how thin a cornea is too thin?
Well, I think you just need to have a residual stromal bed that's, not too thin, and I guess every cornea will be different, but um, leaving a substantial residual stromal bed of 280 to 300 microns is probably necessary. So depending on the refractive error and the thickness of the cornea and the treatment, the optical zone that needs to be treated, it'll be different for each patient, but you'll need to leave a stromal bed of about 300 microns.
Mhm. And for those patients who may not be suitable for those corneal procedures, of course, we always have ICL. And I'm a
Yeah,
can
and I think that's actually a really important point is that I think ICL is becoming utilized more and more and more for any of those patients who are worried about a thin cornea because it is you truly a quite a straightforward and much lower risk procedure with these new lenses and particularly with this with these new diagnostic devices where we can have accurate measurement and sizing of these lenses. Plus, you can do toric ICLs to correct astigmatism as well. So it's the amount of options available are becoming more and more, and really, um, and these corneas that had ectasia risk in the past, we're really, reducing that ectasia risk so much with these anterior detailed, down to 3 micron resolution anterior segment OCTs. We're really, and this epithelial mapping, we're really reducing the risk of ectasia post refractive surgery.
And just to add on to that, Maureen, I'm probably a textbook case here because thin cornea, high myopia wasn't suitable for any corneal procedures. So I went down the path of ICLs. That was over 10 years ago now, and I'm still delighted with the outcome. Okay, so it looks like that's the end of the questions. So we might actually start to wrap up. Again, I'd just like to thank you all so much for your time, for sharing this time and investing your time with us this evening. Welcome to Blink Vision. We look forward to being of service. And again, really look forward to welcoming you into the clinic very soon.
Thank you, everybody. I really appreciate your time.
Thank you
Thank you
so
so much.
much. Good night to you all.